This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This morning we have a very special treat in that Dr. Kim Eagle is our speaker. He almost needs no introduction, as many of you, of course, know, or all of you should know of his work and his contributions in the cardiovascular arena. Dr. Eagle's initial internship and residency was at Yale. He did his fellowship and some additional training at Harvard and the MGH, his cardiology fellowship at the MGH. He was initially on faculty there before going to Michigan in the late 90s, where he is now the director of the cardiovascular center at the University of Michigan. As you know, he has been a major force in cardiovascular medicine and cardiovascular research for many years, and serves editorial roles in all the major journals. You've seen his activities with CardioSource, probably very obvious and frequent on your emails and whatnot. He has had major important roles in the American College of Cardiology, and again has had a major impact on our field there. From a research perspective, obviously he's one of the leaders in outcomes research and has led an absolutely spectacular outcomes research program at Michigan with a big focus on diagnostic testing, acute coronary syndrome, and of course aortic disease, which we'll hear about today. His publication record is with not for the faint of heart, over 600 publications, and probably many of you have spent much of your time citing him in all your variety of work. But really one of those people that's really had a really broad-based and important impact, and not only on the subject matter, but on the importance of outcomes research and helping us define our practice patterns. And so with great pleasure, we welcome Dr. Eagle. He's going to talk to us about aortic disease, aortic syndromes. Thank you, sir.
Good morning. Thank you for coming. It's a pleasure to be here, and I always enjoy getting to see old friends. One of the great things about academic medicine is the fraternity and sorority that we have for our whole lives, and I think as you get a little older, you begin to appreciate that even more, the chance to see old friends who you've worked with in a variety of venues. And so I really appreciate the chance to come to Emory. As far as I can tell, I've never given a formal lecture here, so I'm very pleased to do that. These are my disclosures. You should note that the IRAD registry has major support from several stent companies, so that when I talk about the value of stents, you should recognize that there's a potential conflict. I hope I'll be honest. I try to be honest. And if you know of anybody funding aortic research, please send them my way. Whether business or private, I don't care. So we're going to talk today about where we've been with acute aortic syndromes, the epidemiology, how we classify it, how the patients present, some interesting data on imaging and treatments. And then I'll focus the last half on really where I think we're headed, which is a very interesting place. I think that the future of aortic care is going to evolve rapidly, and I think it's going to be an exciting future. And I look forward to talking to you about that. So this is sort of typically, what we do. We see a patient who has a clinical presentation, and we do a very careful Willis-Hurst-like physical exam and ECG interpretation. We look for predisposing conditions, and we do static imaging and X-ray, routine labs. And we create a diagnosis, and all patients with acute aortic syndromes get medical therapy for life, and some of them get an intervention. And then we put them into a long-term follow-up plan, which is surprisingly not personal. It's a cookie-cutter approach. We think this is the right thing for you. And I would argue that it's pretty Neanderthal, actually. And I hope to convince you by the end of the hour that we need to move forward in a different way in that space. The epidemiology of acute aortic syndromes, particularly dissection, is probably best illustrated in this study. It's about 6 per 100,000 patient lives. Most patients actually die at home, probably more than 50%. Hypertension, smoking, and poorly controlled blood pressure are the most important risk factors that we currently know. There are probably common genetic variants that play a role with environment in causing dissection and sporadic dissection, but we don't know what they are yet. The 5-year survival today, if you get to a hospital alive, is about 85% for both type A and type B. The term acute aortic syndromes actually is three things. One's classic dissection, which you're most familiar with. The second is intramural hematoma, which is probably about 10% of the population. And the last is penetrating aortic ulcer, which is probably a couple percent. How many of you have seen a penetrating aortic ulcer? So most of the time when I ask people, about 10% of the folks raise their hands. It's a fairly rare disorder. Some of you may have seen it and not recognized it. It's a difficult diagnosis to make. The etiology of acute classic dissection and intramural hematoma is interesting. For years we thought that there was an intimal tear with a rush of blood into the media. And then more and more we started recognizing that there was actually hemorrhage in the wall. The vasovasora caused hemorrhage. And we don't know how many of our classic dissections actually start this way. We know that about 10% of patients who present as acute aortic syndromes don't appear to have an intimal tear. And it's conceivable that even more of classic dissections started this way. Reminds you a little bit of coronary syndromes where we know that intraplaque hemorrhage is responsible for a significant percentage of those. The classification scheme for aortic dissection is illustrated in this slide. In terms of anatomy, anything involving the ascending aorta, Stanford group calls that type A, and any patient not having involvement proximal to the subclavian is called type B. And for years, we've had this designation of time. If your dissection is within 14 days, it's an acute dissection. This actually comes from a study done in 1958 in which Hurst, Johns, and Keim reported that the percent dead, it's fairly harsh, the percent dead at 2 weeks was about 70%. This was before the advent of any therapy. And if you lived 2 weeks with a dissection, then the survival curve flattened out and you might live a little bit longer. Okay? So I would like to suggest to you that this is old news. It's not really relevant to today. And with the IRAD group, we've offered a different classification system, which I show here. This is type A dissection. The first 24 hours is the hyperacute period, about 20% mortality if the patients do not have surgery. And notice particularly the first 3 or 4 hours. This is the time when you get the call at midnight, you're in the ER with a patient with a dissection, and you have a choice. Am I going to rush the patient to the OR? Or because they're apparently stable, the surgeon will do the case at 7 a.m. And the answer is there's no such thing as a stable type A dissection. You go to the OR right now. You drag your friendly surgeon out of bed and do this because you're handing the patient inordinate high risk by waiting. From day 2 to 7, we're going to call that acute, and you see we lose another 25% of the patients over that period. And then the next, say, 3 weeks, we lose another 5 to 10%. And indeed, if you live 30 days with a type A dissection, you're going to live a while. Darwin would say, you're tough. So I would like to suggest this is a better classification system in the current era. In terms of the types of problems patients with dissection have, hypertension, of course, you're all familiar with. This one is, I think, underappreciated. So I guess take-home message number 1, prior heart surgery is probably a risk factor for acute aortic syndromes. And it's probably a complicated relationship. Some of these had their aortic valve replaced and they had a bicuspid valve and a mild aortopathy that wasn't severe enough to merit resection, or perhaps the surgeon just didn't do it. Some of them have had bypass surgery and the aorta's been cross-clamped, or they've had a vein graft punched into that aorta. But prior heart surgery is actually 4 times more common than Marfan syndrome in the larger context of acute aortic syndromes. And some of the dissections are actually things that we cause, surgeons and interventional cardiologists. Have any of you ever caused a dissection? Oh, good. So thank you for raising your hand, because I did when I was a first-year fellow. I think it's one of the reasons I got interested in this disease. And it's also one of the reasons I became a non-invasive cardiologist. I recall vividly sliding this wire. It went smooth as butter, and then we injected, and somebody in the next room, an attending watching the monitor, said, "Oh, blank," and came running in and took the catheter from my hand. And the rest is, so shall we say, history. Patient did fine, but with surgery. The problem with dissection is how rare it is, and it's often missed because it's so rare. It's a study from Henry Ford in Detroit, 41,000 patients coming to an emergency department with some type of thoracic pain, and only 128, 0.3%, had a dissection. And so this makes it so hard to diagnose. Many people have never seen it, or if they did, they didn't recognize it. I like this quote from Paul Dudley White. I think it's the best description of the pain that I've ever seen. So pain attending the splitting of the wall is usually excruciating, extensive, radiating mid-thorax, front or back, through the chest, down the back, even into the thighs or into the neck. Here's the key phrase, though. The pain in the thorax or back comes suddenly at its maximum and is often prostrating. Patients who have dissection typically have a photographic memory of when it started. And they will tell you in vivid detail if you ask. And this is very unlike acute MI, where there's no photographic memory. Patient got up, had breakfast, started feeling uncomfortable, had their coffee, and something was building. Dissection is not like that. You know, there's several things in the thorax that are like this. There's gunshot, arrow to the chest, and dissection. They know where they were. And unfortunately, sometimes you get this patient second or third hand. So you're in the ER after they get transferred from another hospital, and their chest pain's gone. And if you don't say, "Listen, ma'am, how did it start?" you'll miss the most important clue to the diagnosis that we have. And the thing that's even more disarming is that often the pain goes away. Pain's gone. Patient says, "It was terrible. I was on the ground for a while. And now I'm fine, doc, and you told me my blood pressure's good and my EKG doesn't look bad. Maybe I can go home now." Not. So this is an important thing to demonstrate. And if you look at, in the IRED registry, this is 2,800 patients, abrupt onset of pain is the best historical clue to dissection, and it's present in both type A and type B. Most of the rest of the patients have fainted. Okay, so like pulmonary embolism, aortic dissection can cause syncope, and the patient may not have a memory of what happened. So that's another thing to remember. Acute abdominal pain is a presentation of type B dissection in 40%. So another thing to keep in mind. The physical exam is not dead. I'm so happy. And at a center that's known for physical diagnosis, you probably already know this. So a murmur of AI is present in about a third of subjects, more than that in type A, and a pulse deficit is present in about a quarter. These are very important findings. No patient in our emergency department with thoracic pain should leave there without a blood pressure in both arms and a careful check of peripheral pulses. Hypotension is common in type A, but normal blood pressure is the most common finding in type A. In type B, hypertension is present in 2/3, but a third of them are normal. So a normal blood pressure does not move you away from this diagnosis if you strongly suspect it. How good should we be at making the diagnosis? Well, this is a look at the guideline, the thoracic aortic disease guidelines that we published a few years ago. And we noted that there are certain high-risk conditions that you should tease out from your history, high-risk pain features, and then exam features. And the high-risk conditions are well known to you. MARFan, family history of aortic disease, known aortic valve disease, recent aortic manipulation, known aneurysm. 5 things. Count them on one hand. The high-risk pain features we talked about: chest, back, or abdominal pain, particularly abrupt, severe ripping or tearing. And then the exam: pulse deficit, blood pressure differential, a focal neurologic defect, AI, hypotension, or shock. And when we tested this on 2,500 patients with dissection and IRAD, what we found is that only 4% had none of them. These would be tough to diagnose. They don't have a high-risk condition, a high-risk pain feature, or anything on exam. Ironically, when they had a chest x-ray, half of them had a widened mediastinum. So if they got a chest x-ray, we figure you could get 98% would have at least one of the markers or abnormal mediastinum on x-ray. And a lot of folks have, most of them have 2 or 3 of these conditions. The chest x-ray is helpful when it's abnormal, but when it's normal, it's not helpful. And how in the world could the chest x-ray be normal with a dissected aorta? And the answer is, well, the aorta is not big. It's ripped, but it's not big. And this calls to mind the problem that we've had. We've equated dissection with aneurysm, which is wrong. There are many patients who dissect who don't have aneurysms. And if they don't have an aneurysm, then when they dissect their aorta, typically it's going to grow about a half a centimeter. And it may not look like a big mediastinum on x-ray. So you can't rely on that feature at all. And the EKG, of course, I've written in textbooks that the EKG is very helpful in dissection when it's normal. Well, it's rarely normal. Most patients have nonspecific changes, or they have ischemia, or they have an infarct. That's really tough. If they come in with a STEMI, and it's from a dissection. I hate it when that happens. Now, thankfully, there's only about 300 or 400 of those a year in the United States, but they get a lot of press. So a normal EKG is helpful because it moves you, away from ischemia, which is far more common, but a lot of patients have evidence of ischemia. If we look at imaging, the most commonly used test around the world is CT, followed by TEE. And if we look at the sensitivity of our current diagnostic technologies, CT and MR are both around 98%. For type A dissection, TE is going to be in the high 90s, but for type B, it's less effective. It's not as sensitive. So that's why this data. But for ruling out type A dissection, it's quite helpful. So what is the size of a normal aorta? If you go on rounds with me and I ask a question of the house staff, if they're smart, they'll say, it depends. Because the answer is it depends, of course. And that is how you're measuring it, where you're measuring it, and who are you measuring it in. Clearly in the sinuses, or the ST junction, or the tubular aorta, or wherever. The aorta tapers as it goes down. And of course we know that men and women are different when it comes to aortic size. On average, throughout the lifespan, women have smaller aortas. We also know that the larger you are, the larger on average your aorta. And how you measure aortas is important. If you do axial imaging like this, where you don't establish a center line and get perfectly perpendicular to that, aortas can look a lot bigger because of the way you cut the film. And this can be a real problem. We studied this in the GENTAC registry. And in axial methods, the white is axial, 44% of patients met surgical criteria with their initial imaging, but when those were reread with a double oblique, it dropped by about a third. So this is very important. When you measure aortas, you need to do it the right way. You need to trust whoever's doing it. It's best if you see the images yourself. But if you don't, you want to trust whoever's giving you the information. I had an experience just last month. I see a guy from Palo Alto who comes out for his aortic care with me. And his aorta last year was 51. And his aorta this year was 55. Well, gosh, 55 is the surgical cut point. So I got my favorite aortic imager, and we put his images up, and we looked at last year and this year. And last year was probably an undercall. It was probably 53. And this year was an overcall. It was actually about 53. He hadn't changed. And this is just an example. We consider a 1/2 centimeter growth in a year to be important. And if you reach a cut point and you've grown a 1/2 centimeter, that's a surgical decision. But his aorta hasn't changed at all. So you got to see the image or trust the people that are reporting it to you and make sure that it's accurate. And this illustrates this point I made a few minutes ago. The IRAD investigators studied the aortic size of dissected aortas. These are patients who'd already dissected, and I said before, the aorta grows when it tears typically, usually about a 1/2 centimeter, 0.3 to 0.5, maybe 0.6 centimeters. So even with that taken into account, a lot of patients who dissect have pretty small aortas, and not a small fraction have normal-sized aortas. So we have to get it out of our minds that dissection and aneurysm are absolutely linked. Sometimes they are, but not infrequently they're not. So the treatment for a type A dissection is medical therapy for life, surgery as quickly as possible, and we'll sometimes fenestrate the aorta in a patient who's not a surgical candidate. This is a technique where you equalize the pressure between the true and the false channel to try to keep the false channel from expanding. The notion here, of course, is that false channel doesn't have normal elastic tissue buttressing it because the tear is someplace in the plane of the aortic media. And so theoretically, if you fenestrate and create equal pressures, you might reduce false lumen expansion. Not proven in randomized trials, but occasionally our surgeons will recommend that if they think the patient is not operable. Over the years, our surgeons have become more aggressive. This looks at the number of type A patients who are going to the OR over time. This is over 3-5-year increments, and it's now almost 92%. And of course, the death rate is falling as surgeons are taking on more of these patients. So this is the number of patients not operated, and this is the mortality, all comers. If you see a report of like a 3% mortality with type A dissection, often it's a single institution study by one surgeon who's kind of doing this. And not infrequently, if you read the methods, the patient will have to have left the operating room to get into the study. So that's a problem. So IRAD is all comers. If you arrive in the ER alive, you're in. Okay, so this is the truth for patients coming to the ED with this disease, not the folks that have survived long enough to get to the operating room and so on, and leave the OR. For type B, uncomplicated, we use medical therapy. If they have a big false channel or an aneurysm, often a stent or surgery, depending on the situation. Stent graft therapy is evolving. This is data we published a few years ago, suggesting that the 1-year survival in a patient who gets a stent graft for acute type B dissection is about 91%. There are several very important studies that further illuminate this issue. This is one. One of the co-founders of the IRAD registry is Chris Neinaber, who's an outstanding interventionalist. He initiated the INSTEAD trial in Europe, which is a randomized trial of patients to medical therapy or stent graft therapy for subacute type B. And at a year, reported findings suggesting that stent graft therapy had an early hazard. What's interesting is in the follow-up, at about 2 years, there was a crossover, and the optimal medical therapy group appeared to do worse than the group that got thoracic endovascular repair. And when he looked at the data, the folks that got TVAR had larger true lumens and much smaller false lumens. And we think this is where the action is in terms of late aortic risk and rupture. That false lumen progressively expanding and then rupturing over time. When we looked at this in the IRAD registry, what we saw was that after you risk adjust, it did appear that there was a crossover where the endovascular group had improved survival, not as large as what was seen in INSTEAD, but suggestive that there may be a late benefit in aortic remodeling to stent graft therapy. Here's an example of stent graft therapy in a patient with a fairly large type B dissection and a nice result. This is what you're looking for. So current indications for TEVAR are aortic instability, hemorrhage outside the wall, of course malperfusion, expansion to a very large size, or an annual increase of the distal aorta of more than 4 millimeters, or of course hemodynamic compromise. When we looked at what's happened with stent graft therapy over time in the IRED registry, type B dissection around the world are more frequently getting endovascular treatment compared to open surgery. And of course the advantage here is if you do open surgery, typically you've got to cross-clamp the aorta. So often a patient has a malperfusion syndrome, and you exacerbate the ischemia by the operation itself and further increase the chance that the gut will die or a leg will die or a bowel segment will die. And endovascular therapy offers potentially the chance not to further cause insult on a malperfusion syndrome. And so far it looks to us like the survival data is going to favor a larger role for stent graft therapy in the right patients. So how to follow these patients? Well, we need to treat them, we need to watch them, and we need to educate them. The treatment, if you look at long-term survival, this is IRAD data. 5-year survival is around probably 85%. Type B patients actually do worse over the long haul, probably partly because they're older and they have more atherosclerosis, more renal failure, etc. If we look at what happens to patients who've had dissections, nasty things happen in follow-up. These are patients who had dissections of type A variety, and of 115 survivors, not a small percentage had aneurysms, dissection, false aneurysms. Their aorta is not normal. It's very important when we discharge a patient with a dissection for them to understand the notion that we didn't fix them. We palliated an acute problem, and they have a diseased aorta for life. They can never go off their medications. They shouldn't miss follow-up surveillance imaging, and they shouldn't miss follow-up. You know, one of the most important things for our patients is to know that you can't run out of your meds. This happens to me every week in clinic. Somebody shows up, and you're taking your statin. Well, you know, Dr. Eagle, you changed my appointment. You were in Atlanta, and you didn't make your appointment, and I ran out. So it's your fault. So we have to make sure these patients, if they're on 3 or 4 antihypertensives, if they suddenly go off 1 or 2 or all of them, that is really a risk for progression of their disease. Type B patients also have bad things happen in follow-up. Here's 50 patients, fatal rupture in 9 and a major aortic catastrophe in 10. Almost 40% over a period of years had a nasty follow-up. So what's the best long-term medical therapy for aortic dissection? Well, I'm not sure, and neither was George W. We know about mechanisms, so we have a lot of information about the role of angiotensin and AT1 and MMPs and shear, and we can affect these with beta blockers, ARBs, ACE, statins. But actually, the randomized data is really lacking, isn't it? In fact, the only great randomized data we have for preventing dissection was a Turkey model of aortic dissection, the mid-60s, right? You remember Wheat and Palmer? Some of you are old enough to remember this. There was this model of turkeys, if you fed them a certain type of nut, they would dissect their aortas. And if you fed them nuts and then randomized them to beta blocker or placebo, nuts plus beta blockers did better. So if turkeys are making a resurgence in our country, by the way, we have 30 or 40 in our backyard. So if you ever encounter a turkey eating nuts, give them beta blockers, okay? But as far as randomized data, we don't have a lot. We have this is the New England Journal study, first one looking at beta blockers in young Marfans and a slowing of aortic growth. I did not put in the slide kit the more recent randomized trial, pediatric trial, suggesting that beta blockers and ARBs are both effective in helping retard aortic growth in Marfan syndrome, but that's a very small percentage of our subjects, and we don't know that we can translate that biology to the sporadic dissection at all. Ehlers-Danlos, it appears that beta blockers have a benefit in improving aortic protection, and we have non-randomized data such as this, patients who've had repair of type A, who stayed on beta blocker therapy versus those who did not. where at 15 years it appeared that the group that did not get beta blockers did worse. It was adjusted, but you can't tell. You can't tell. When we look in IRAD about in-hospital survival, we see data that beta blockers appear to be protective. And interestingly, patients who got ACE inhibitors did worse. This may just be patients had tougher hypertension, or maybe ACE inhibitors were causing hypotension and worse malperfusion. Reminds you of some of the ACE inhibitor trials for heart failure, where overdosage led to more harm because the blood pressure was in the 80s. In Marfan syndrome, we know that if you add losartan in adults to beta blockers, this is a randomized trial done in Europe, suggested that the aortic root was smaller, whether you measured it by MR or TEE, if you use losartan on top of beta blockers. And this is adults. You're familiar with the pediatric trial just compared losartan at high doses to atenolol at high doses and showed roughly equivalence. But in adults, there is data for the Marfan patient to add losartan on top of beta blocker. Long term, typically what we say is heart rate less than 60, blood pressure at 120/80 or less. We want to use ARBs in Marfan or Loeys-Dietz. Statins if they have atherosclerosis. We don't know about anticoagulants. Don't know if they're effective or harmful. And we watch for aneurysm formation. The guidelines say image at 1 month, 3 months, 6 months, and a year. Why is that? Because that false channel may grow rapidly after discharge. If you think about the aortic wall, intima, media, a little space of adventitia, that tear is somewhere in that media. If there's a lot of media buttressing the false channel, it's not going to expand. If there's very little, if they're living on a thread, so to speak, it may well expand and do it rapidly. And so if you bring them back at 6 months, you may find that they died before they get to follow-up because their false channel rapidly expanded. That's why you have to be aggressive with surveillance. This is really a shotgun approach, and we need to get better in predicting who's going to expand. And I mentioned this, educate the patient about a lifelong disease, symptoms to watch for, activity, meds, follow-up. I don't like my aortic patients to compete in any sport. I don't like them to water ski. I think, I don't know about you, but water skiing, typically you fall down. If you stay up long enough, you fall down. You don't want them to play rugby or things that they're going to take a major aortic blow to the chest. And follow-up and meds we mentioned. I think the future is much more interesting, and personalized medicine is a buzzword, but it really does apply to aortic disease. I think the future is that we'll be doing more dynamic imaging, we'll have better biomarkers, we may have more on genetics, and that we'll all put this into our therapy, diagnosis, and treatment, and then the patients will have a tailored approach based on their clinical evaluation, static and dynamic imaging, genetics, and hopefully chronic biomarkers. I think we'll get much better in the next 10 years in treating this condition. You're familiar with the genetic disorders that cause dissection, Marfan's we talked about, FBN1 mutations. Loeys-Dietz, these are young people that look Marfanoid often. They have TGFBR1 and 2 mutations. Ehlers-Danlos is COL3A1 mutations. They have other problems with their GI tract or their uterus, rupture of median arteries. Don't forget Turner's. These women have coarctation bicuspid valves and they can dissect. And I'm not going to hammer you with Marfan. You've all seen this picture. But this is one you probably should remember. The Loeys-Dietz patient has often aortic, carotid, subclavian aneurysms, and they often have a bifid uvula. After I heard Hal Dietz give this talk, I actually went to the restroom and opened my mouth and looked in the mirror because I hadn't looked at my uvula in a while, So this is always on the boards, but it's also something that's worthwhile. If you see sort of a gangly kid in your clinic with a little funky aorta, look at their uvula. The number of genes that are known to cause familial disease is growing steadily with a great investigation by families. This is Diana Milowitz data from Houston. The ACTA2 mutation is the most common, but all told, we have now about 25 to 30% of families will now map to a known genetic defect. And of course, this is incredibly helpful for following their first-degree relatives. For instance, John Ritter, he had an ACTA2 mutation, probably killed his father. His father, Tex, was also an actor, died suddenly, was thought to be an MI until John had his dissection, and then people thought, well, maybe Tex was a dissection. And John had an ACTA2 mutation, and one of his 3 kids has it also. But we've been sort of over here, single gene disorders, and where we need to get to is over here, identifying more common variants that interact with an environmental stress to cause dissection. So the future of the genetics of this set of conditions is, I think, really interesting. Hard to get at, but I hope in my lifetime to see some of these begin to be elucidated. We kind of know what's going on. We know that whether it's a genetic or acquired condition, there's this interaction between smooth muscles, matrix production, and matrix degradation. And the losers are the ones where there's matrix degradation and the wall is weakened. We know that MMPs are involved, IL-6, we can measure CRP, it is a predictor but not strong. So we have a sense for the workings of this, but we're not real close to the solution yet. And this slide makes me want to be happy that I'm a population biologist, because these are the interconnectedness of the genes that affect the aortic wall. And when I look at slides like this, I'm glad that, like Leslie, I'm following populations and not trying to figure out these connections. I guess take-home message number 3 would it be, is when you see a patient with bicuspid valve, never forget to screen their first-degree relatives. They must be screened. 32% of them will have an abnormal aorta. Very important, and very frequently missed. Very frequently missed, even by reasonable cardiologists like you. When you see bicuspid valve disease, never assume that they've been screened. I saw a patient last week, he's 65, he's had a BAV for 40 years, known. And no one had ever told him to have his first-degree relatives and his kids screened. He has 6 kids. 1 or 2 of them is probably going to have disease. You must do that. The indications for repair in bicuspid valve currently, the echo guidelines suggest a diameter of 5.5 or 5 if there's a family history of dissection or an annual increase in size of more than 0.5 centimeters. And we do the aorta with the valve, so if you're doing the aortic valve, if it's 4.5 or larger. This is slightly different than the TAD guideline committee that I was part of, because the surgeons argued vehemently that we should have a lower cut point. In the next 3 months, you'll see the 2 committees came together, and there's a slight number 4 here that I think is sort of it's a bone for the surgeons, but it's not going to dramatically change this. In terms of follow-up, the recommendation would be that if the aorta is less than 45, probably you would screen it once after you find it. If it's a big aorta, you screen it once after you find it, maybe at 6 months. And if it's not growing, then if it's less than 45, probably every other year. If it's in this range, probably annually. If it's in this range, you're going to be doing it every 6 months, because these can move a lot. And if it gets to 55, then you're going to go ahead and repair it. The Marfan patient at 50 is going to get repair. The BAV patient at 50 is going to get repair if they have a family history or major growth. Okay? So it's a fairly simple algorithm that I think is useful. Searching for a biomarker, wouldn't it be great if we had a troponin for aortic dissection? Wouldn't that be great? Are there any sensitive biomarkers for acute aortic dissection? Raise your hand if you think there are. Well, there is. I'm so glad I came. It's true. There's a great biomarker for acute aortic dissection. Now, it could be any one of these: TGF-beta, smooth muscle myosin, heavy chain, CRP, fibrillin fragment, or D-dimer. And it's going to be D-dimer. We've looked at CKBB, myosin, calpanin. None of these has an early sensitivity that is adequate to be used for acute dissection. But D-dimer is extraordinarily sensitive. There is clotting going on in acute dissection. And 97% of patients have an elevation in D-dimer, and it's usually massive. And it's remarkably unknown. It's remarkably unknown. This is a study that we published a few years ago looking at D-dimer in acute dissection type A and type B, and then MI patients, angina, and PE patients, just a couple. These are the early presenters. And look at the size of these elevations in the thousands. Even at 6 to 12 hours, dissections are up there. Some patients with heart attack have clot in the ventricle, and their D-dimer goes up. And of course, PE eventually will get there. So it's not specific. But if you see a patient with thoracic discomfort and a D-dimer of 1,000, there's a very good chance that that is a dissection. It's really amazing. What about other markers? There's a lot of interest in TGF-beta levels. TGF-beta is very involved in aortic disease and Marfan syndrome. And if you look at Marfan mice, they have high levels of TGF-beta circulating in the circulation. If you give them losartan, it goes down. This gives hope that maybe this could be a chronic biomarker that we could follow, at least in patients with Marfans. And if you look at aortic size in mice, there is some correlation between the amount of TGF-beta and the aortic root size. In humans, we know that Marfan patients do have high levels TGF-beta, and it does go down some if you treat them with losartan. But my friends tell me it's been very difficult to create a diagnostic platform, particularly a point-of-care platform for TGF-beta. Part of it is that there's a lot of this circulating with the platelets, and it's not yet ready for prime time. It may come. It may come. CRP is elevated in dissections and does predict long-term death, but it's not a highly sensitive marker. Neither D-dimer certainly predicts death over time, and I showed you that it's an acute biomarker, but it's not specific. It's very sensitive. It calls to mind the question, if we could find a specific biomarker to put with it, then we really might have it. You got a sensitive biomarker and then one that's more specific. That would be cool, and I'm hoping it's going to be this one, fibrillin fragments. Lynn Sakai and her colleagues in Oregon, along with Scott Lemaire in Houston, have reported that fibrillin fragments are elevated in patients with aneurysms, particularly fibrillin 1. And if you look at patients with acute or subacute dissection, they are much more likely to have high levels of fibrillin 1. So they're working right now on this notion of a platform of fibrillin 1 and D-dimer as a possible dual biomarker for acute thoracic pain in the ER. Dynamic imaging is something that needs to come. There's so much information on images, and we kind of say, well, how big's the aorta? And we're not really looking at it like we should. Here's a study that we did looking at partial thrombosis of the false channel in patients with a type B dissection. What does this mean? And what's really interesting is we observed that patients who developed partial thrombosis after they originally had complete flow in the false lumen did worse. And we hypothesized that maybe they're closing off their reentry sites and creating this blind pouch. We created an in vitro model of dissection in the engineering school, and we showed that when you do this, you raise the diastolic pressure in the false channel, and that may drive expansion up high in the aorta. Or maybe it's something about the blood. Maybe the blood is interacting with the wall in such a way that there's further destruction of elastic tissue. We don't know, but certainly this is a predictor. Partial thrombosis is a nasty problem to have. This is a physician that I was caring for a few years ago who, had this, and then I think it was a year later, he partially thrombosed, and he clearly was growing. You see, his true lumen was getting smaller, and his false lumen up here is getting bigger, and this is not attractive. And he ended up with a stent graft to try to prevent further expansion or rupture. The future of dynamic imaging, I think, is really, really fascinating. This is an MRI study of a bicuspid aortic valve patients who dissected, showing the flow patterns in the true and the false channel. And it's really quite interesting to think that we can actually image flow patterns pretty well, and we can measure how much of the blood flow is helical versus laminar. And if we can do that, maybe that correlates with wall stress and risk. Here's the kind of aorta you'd like to have, tricuspid valve, beautiful laminar flow. That's what you want. Here's flow that you'd rather not have. This is a bicuspid valve, and look at the turbulence in that ascending aorta. And Rachel Clough and her colleagues in London have measured the amount of helicity and what happens to the false lumen, and showed evidence of a correlation. That maybe we could measure how the blood is flowing, and it would allow us to say, well, you need to be seen in 3 months and you should be fine for 9 months. So the future, I think, of dynamic imaging is we're just scratching the surface, but it's bright, and I think it's going to really lead to patient care that's better. Maybe we can even find places where we're going to find entry tears in the future. The first publication of dissection was King George II, 1760. He went to the closet, I think that's the bathroom. First he got up at 6, like you do, and had his valet de chambre brought him his chocolate. And then he went to the bathroom, and the valet de chambre heard a sound which he likened to the royal wind. And he was there and he was dead. And he had a type A dissection. This is the first description of pericardial tamponade from a dissection. So think about that. I mean, that's, 250 years ago. And how far have we come? But how far do we have to go? Charcot said this: disease is very old and nothing about it's changed. It's we who change as we learn to recognize what was formerly imperceptible. And this is the moment for us. We have genetics, we have modern proteomics, we have much better imaging, and we have a lot of bright people at places like Emory. And we need to attack this scientific frontier. It's right in front of us. Obviously, I presented to you a lot of work from a lot of folks. These are the current 41 IRAD centers around the world. The people who founded IRAD, Eric Iselbacher and Christoph Neinaber, I'd like to mention. Also, I know this morning Santi Trimarchi in Milan is watching this. Santi and Himanshu Patel are running our interventional part of IRAD, where we're trying to get at specifics about surgery and interventional therapy to get more information about the best possible strategies for therapy. So I want to recognize them. These are some of the places that participated in our bio-IRAD research looking for biomarkers. I've had to go to Italy on multiple occasions, which is really a chore. But I'll go back again in a year and a half. I'm part of the GenTech Registry. I'm the chair of this group of amazing scientists, people at Hopkins, Oregon, Hawaii, Houston, Baylor, Cornell, Penn. The work on the imaging and genetics that we've done is fascinating, and I've enjoyed that collaboration a great deal. And I work at a place that's got an amazing group of folks working on aortic disease. And I don't have time to acknowledge all of them, but I respect them and I appreciate the chance to be part of that team. Osler said there's no disease more conducive to clinical humility than aneurysm of the aorta. Now, I've been studying this disease since 1983. And I feel like when you've seen one dissection, you've seen one dissection. They're all different. They're all challenging. And they're all fascinating to me. A final shout out, I'd like to acknowledge some of the folks who are important in my life who allow me to be where I am today. In terms of mentors, I've had 1,000 mentors, but I typically call out a few. Larry Cohen at Yale, who really taught me the joy of cardiology and professionalism. Roman DeSanctis at the MGH really introduced me to aortic dissection. George Thibault there, who's now at the Macy Foundation on outcomes and guidelines. And I worked with Valentin for several years. He taught me to think global. Any patient anywhere in the world today might be part of your research study. That I learned from him. Of course, I want to honor my parents who taught me the value of hard work. This dude was a very interesting fellow. When I was a fly fishing guide in Yellowstone, and I was his guide for a number of summers. And when I was in college, he asked my parents if he could pay for my college education. And then when I went to medical school, he asked them if it might be possible to pay for my medical school education. So he had a profound effect on my life. My dad was a high school teacher. There's no way I would have gone to medical school without the investment of this person. My wife, who allows me to go on speaking trips like this, my son Taylor, and countless others, particularly patients and their families and the students who've made my journey in academic medicine such a joy. So I like to acknowledge them. You know, these are the things that really matter in my life. And I do appreciate the chance to come to Emory and give you a talk on aortic disease. Thank you.
Thank you, Dr. Yale. That was a fantastic presentation. We'll have some questions here, and we'll have some remotely, maybe, if people chime in. I'll start with one. So, as you presented sort of the demographics and of the IRAD group, and the average age is about 65, a little more male than female. What about the young dissection? I mean, we see an awful lot of young, particularly African Americans with severe hypertension here. Is that a different beast? You said you see one, you've seen one, but is that a sort of part of that? Because it does seem like a different disease to many of us, I think.
So I agree with you that certainly the African American population with earlier tough hypertension may come in with their dissections earlier. Obviously, if there's a subset of IRAD which is a very urban poor, smoker, hypertensive, occasionally cocaine users. That's a really nasty combination, but smoking plus hypertension or smoking plus cocaine, really bad risk factor for dissection. Is there more than that? Probably. There's probably some genetic variant that is playing a role here. There's so many folks that have these diseases, but so few dissections. What is it? The environmental triggers look the same. There must be a genetic component that we haven't identified yet. But if there's no family history of sudden death or something like that, then we don't know. At the moment, I'm not sure it's appropriate to screen all of them if there's no family history, unless they have the wherewithal to do that, because it's really a fishing expedition at this point.
Questions from you? Please use your microphone.
One thing that's always intrigued me is the type B dissection and whether we're undertreating them. Is there one you think is wrong to try to stent graft all these people, or is there a group of type Bs that you say this is who I would stent graft? Because you look at the natural history of type Bs, they have a lot of trouble downstream. I mean,
yeah, they do. Yeah, it's a really good question. So there's a group there that I mentioned that we definitely would do. So that if it's big, if they partially thrombose it, if it's growing, that's for sure. The others where the type B dissection is, it's not a relatively large aorta and there's no malperfusion at all and there's no blood outside the lumen. We just don't know. We're in discussion with the NIH about a randomized trial that would try to look at about 3,000 of those patients and randomize them to best medical therapy or stent graft therapy plus medical therapy. You saw that the use of stent grafts is growing over open surgery, and there is now an indication for stenting of acute dissection, so that we're seeing it grow more in Europe than here, I would say. And I wish we could do the trial. It's very difficult to do these trials. It's such a rare disorder that we're going to need over 100 centers to randomize, a relatively modest number of subjects over a couple of years to do the trial. And then you got to follow them at least 4 to 5 years to get even a soft endpoint like aortic biology. If you do an endpoint trial of death, stroke stuff, it's going to take even longer. It's a great question. It's one of the big questions facing us.
So Callum McRae in Boston is talking about people with heart failure. You can sort of figure some of them out ahead of time because they look different. And some of the patients who get aortic syndromes look different. And Flo Hyman, for instance, the volleyball player who tragically died of Marfan's.
Sure.
You know, she looked very different.
Right.
And so is any of the registry going to look at the physical characteristics and start to sort some of this out? One of them, of course, would be very HIPAA intolerant, would be pictures and other things.
Sure.
Which we would expand beyond the usual.
Right.
Because some of these people clearly look different. What can I say? So.
Well, you're right. Yeah, there probably are phenotypic clues that we haven't fully elucidated. There's no doubt that's true. What's difficult, though, I guess, is that the way they look and the way their aortas look are often entirely different, right? There are examples of Marfan twins where one of them has the phenotype and the other one doesn't. And they're identical twins. So, how does that happen? And so, if you start saying, everybody I see on the street that's got slightly wide eyes or a tall, lean figure is going to get screened, it's phishing. So I agree with you. We need to do better in figuring out the phenotype-genotype correlations. And one of the work, the Gentac group is working hard on that to try to get more clarity. But it's tough. I'm evading your question because I don't know the answer. Yes, sir.
So I hope you taught your clients how to catch those cutthroat trout out there in West Yellowstone.
Mr. Hopkins caught a lot of fish with me.
I was fishing there one time and I was trying to throw it way out in the middle of the river, and my son was standing right over there, and I looked back at him, there's a trout right behind him. So that was a tricky fish. Now, it seems to me that we may be talking to the wrong group here, in that the first shot at them is a screener in the emergency room or the emergency room physician when they come in. So they've got to decide what tools they have. And the history, of course, of those 2 points about sudden onset, pain to the back, I remember when that was, that's one thing. Then they have to decide what to do next. Well, do I consult cardiology? Do I order an echocardiogram, transthoracic? Do I do a chest x-ray? Let's see, that's going to be a portable because the patient can't stand up. Or do I order a TEE, or how do we make this diagnosis? So it's a little confusing. It depends a little bit on what you have available to you as to what you order. Usually when we get involved with them, they either come in on a helicopter or the emergency room physician has ordered a CT scan. So in making the diagnosis, somehow we need to move that back and decide. I've always been interested in how you make this diagnosis on transthoracic echo. And, but it's confusing down there to them, I know, and we may be talking to the wrong group here.
So I'm talking to the group that invited me. So you're right, of course. We've done some work where we took the thoracic guideline and we created pocket guidelines. We distributed that to several thousand emergency room docs. We've had an educational program directed at those folks. Probably the best example of what would be best is in the Minneapolis area, the Minneapolis Heart Institute has worked with all of their catchment hospitals. They've delivered an educational format to all the emergency departments. They have a 1-800, it's just like your MI, and have shown that they've been able to detect and deliver the patients to the mothership much more reliably and quickly. So your aortic experts hopefully are working with the emergency departments in your network so they know the clues and the diagnostic tests, and they have a 1-800 number where they can call and boom, that patient gets moved super fast to your aortic center. That's the ideal. And we need to do that better, and I totally agree with you.
We'll do 2 more quick ones. We have one online, and then we'll do Alessandro. Online wants to know any comments, Stan's room wants to know any comments on watching a penetrating ulcer.
So I didn't talk a lot about penetrating ulcer because it's so, it's more rare. Clearly, the problem with these is that if they're large, they can cause either rupture, dissection, or intramural hematoma. And so if it's a limited segment, it's a fairly large ulcer, we're going to stent graft them. We're not going to leave them alone. We think they tend to do bad things over time. Obviously, what happens depends on how deep into the media and adventitia this is and whether or not there's hemorrhage. But they're nasty. They're nasty problems.
Last one, Alessandro. So, warning, he's a mathematician.
He's a mathematician.
I'm working with Santi Trimarchi at University
I'm
of
so glad
Pavia.
you're here.
I'm glad to be here because your talk was very inspiring for me. So with Santi, we are looking at the fluid dynamics in particular in several patients. We have in a project called iCardio Cloud where we are creating an infrastructure to bring rapidly images from the San Donato Hospital to the university, and we are doing our computational analysis. So I'm really happy that you address this quantitative perspective for understanding and giving suggestions to the patients. But my question is about fluid dynamics. You mentioned helicity. What else? So what kind of quantities may be of interest for you? We can compute many things in terms of hemodynamics.
You can do
fluid
anything,
dynamics.
yeah.
Yeah, pressure,
Well, so,
stress, oscillatory shear
So if you think about what happens to an aorta, it probably has to do with the blood pressure, both in systole and diastole, flow patterns, and obviously how the tissue is. So we can use imaging to look at all of that. And we should be able to study the elastic elements of the aortic wall. As I've shown you, we can study flow patterns, and we can certainly get a sense for size. And all of this should equate to much more personalized information about the vitality of an aorta, whether it's elastic or not, whether it's thick or not. Obviously the worst thing is a stiff aorta in some ways, right? An old stiff aorta is not elastic. It absorbs all the shock, and that's an aorta that's a problem. So I think we're just in the beginning of this, right? I think Winston Churchill said at the end of World War II, somebody said, well, so this is the end. He said, no, it's the end of the beginning. And that's where we are with aortic disease. We're now on the cusp with genetics, biomarkers, and imaging, and technology, percutaneous surgery, to completely change the field. And I'm looking forward to watching it, hopefully as I grow old.
Thank you.
Thank you very much.
Well, thank you very much for fantastic.
The preceding program is copyrighted by Emory University.